Good morning, good afternoon, and good evening. My name is Mark Linwood, and today we're going to be delving into the world of the management of seizures. As we know, there are many different types of seizures, but today we're going to be focusing on the tonic-clonic aspect. And we may delve into a little bit of the management when it comes to a patient in status. So what are we going to be going over today? So the topics we're going to be going over in this presentation, we're going to be looking at the definition of seizures and the etiology or the causes. We're going to be looking at the physiology of the neuron, as well as the pathophysiology of the seizures. Clinical features will be coming up next, as well as physical examination and the investigations that we can perform for these patients. Then we're going to be looking at the pharmacology, more so the first and second lines. And no surprise, but we will talk about the management. So as I said, we'll talk about the basic management for our tonic-clonic and then delve into a little bit of when they present with status. Then we'll be looking at transport considerations and last but not least, some leadership and teamwork, and we'll end with some references at the end. So the definition. Now, the World Health Organization defines seizures as excessive electrical discharge from a group of brain cells. Now, with our partial seizures, we know that these discharges come from one particular area or one focus, whereas your generalized tonic-clonic, there are randomized discharges from all over the place at random times. So bear with me, picture your brain being tasered in random places at random times. So that sudden surge of chaotic electricity causes involuntary muscular movements and intense muscular contractions. So we see this when we have a patient who's in a shockable arrest, and we provide them with defibrillation. They have that sudden, intense, increased muscular contractility. So the causes or the etiology. So these are the common ones that we will generally be faced with. So starting off, we've got our vascular causes, so our ischemic and your hemorrhagic strokes. We also see the hypoxic strokes. They're not uncommon, and you will see them a lot in the patient that is just about to arrest. And of course, we have our ABIs due to whether it be a chronic ischemic area or vascular malformations due to the underlying cause. Infection, so we've got the common one being meningitis and encephalitis as well. Trauma, so subdural and epidural hematomas causing increased pressure within our cranial vault and resulting in a TBI. Metabolic is a big one. So we've got things such as our hypoglycemia, we've got electrolyte derangement. So the main ones being our hyponatremia, hypocalcemia, and hypomagnesia, as well as a bit of B12 deficiency and some hyperthyroidism. Because as we know, those patients are constantly at an increased basal metabolic rate, sorry. Next, we got idiopathic. So that covers epilepsy, and we can put in what used to be known as the pseudo seizures, which are now the non-epileptic psychogenic seizures. Neoplastic. So these unfortunate souls are the ones that have either brain cancer or cancer which is metastasized to the brain, resulting in things such as meningiomas or even space-occupying lesions. Drugs and toxicology, very common one. So we've got our opioid overdoses, we've got our TCA or our sodium channel blocker overdoses, and our amphetamine overdoses, and that sort of leads down the more serotonin syndrome path. We also have our alcohol and drug withdrawals, alcohol being quite prevalent. And we live in Australia, so envenomation is a big one. So not only do we have our snakes and our spiders, but we also have the marine wildlife, which causes. And I'm sure a lot of you work in the rural sort of farming communities. So you will see things such as sort of fertilizer induced, so organophosphate type induced seizures. Pregnant population, so we've got the eclampsia, so that's severe hypertension, that pre-eclampsia phase resulting in eventual eclampsia, and for the pediatric, more so the pediatric population, but the febrile convulsions. So the physiology. So how does the neuron actually create an action potential? So on the picture to, I guess, my left, your right, essentially, you'll see the neuron with green markings and red markings. So the neuron has two pathways. It has an excitatory, which is denoted by the green marking, so green meaning go, and the inhibitory pathway, so red meaning stop. Now, the excitatory pathway is made up of two receptors. It's got an NDMA and the AMPA. I'm not even going to attempt to say these names. And glutamate is the main excitatory neurotransmitter for those pathways. So what happens is the glutamate is activated, and that causes an influx of positively charged ions, being calcium, magnesium, and sodium. These ions create the neuron to become positive, resulting in a depolarization, creating an action potential. Now, the inhibitory pathway contains GABA receptors, and there are multiple GABA receptors, and the main inhibitory neurotransmitter is GABA, so the gamma aminobutyric acid. So what GABA does is it regulates that depolarization by providing a negatively charged ion, being chloride. So what chloride does is it puts the neuron in a state of hyperpolarization post the action potential, so that the neuron doesn't have an increasingly produced action potential. Now, the pathophysiology. So there are two ways in which seizures can occur. So the first way we'll be looking at is the excitatory pathway. So what happens there is we get an increase in our glutamate activity or glutamate production. So what happens there is large amounts of those positively charged ions, so those sodiums, those calciums, magnesiums, enter the neuron, making it more positive. What happens when the neuron becomes more positive? It begins to depolarize, resulting in increase in action potential. That increased action potential results in abnormal, chaotic excessive electrical activity within our central nervous system, resulting in the symptoms that we'll go over next. Second way that seizure can occur is due to the inhibitory pathway. So what happens is we get a decrease in our GABA activity or production, or an actual failure of the GABA receptors. So what happens there is we get a decrease in those negatively charged ions, being the chloride, meaning that the positively charged ions can enter the neuron sort of unopposed, resulting in the neuron becoming more positive, resulting in depolarization, providing increased action potential, resulting in that abnormal excessive electrical activity within our central nervous system. So the clinical features. So with the generalized tonic-clonic, they're going to be in an altered conscious state, generally GCS3. Now we have to remember that they have such intense muscle contractions. So we're going to see things such as potential airway compromise. So the jaw is going to be, those mastication muscles are going to be clenched shut, resulting in trismus. We're going to have pooling of the oral secretion, and that's all due to the oropharyngeal muscles. Potentially they'll have deviated gaze, and that's due to contraction of those extraocular muscles. Then we've got the classic tonic-clonic. So we're going to have that synchronous bilateral limb jerking activity. We'll generally see a tachycardia and hypertension. So one reason is some people say that it's an increase in our autonomic activity. However, a normal human can generally tolerate seizure activity for or compensate for seizure activity in about 20 to 40 minutes. So what happens there is it increases cerebral blood flow by increasing our heart rate and our blood pressure, and increasing that cerebral and causing cerebral vasodilation. We may see incontinence, and that's due to that sphincter tone muscle release, funnily enough, and that can be either urinary and or fecal incontinence. Once the body starts to decompensate, so we get an increase in our lactate levels and decrease in our pH, we also get a decrease in blood sugar, electrolyte depletion, and the body is going to generate quite a significant amount of heat. Physical examination and investigations. So we're going to be using our eyes first. So we're going to be looking at the skin color. Are they cyanotic? Do they have diaphoresis? Do they have any of those symptoms that we've just mentioned in the previous slide? And of course, when we're on scene, we have to keep a good situational awareness. So is there evidence of the cause of the seizure on scene? So we're looking for used syringes. We're looking for track marks on the patient, empty medication packets. We're going to be looking at evidence of head trauma. And depending on where we are, if we're out in the bush, say, is there puncture marks? Is there snakes around or spiders? And in the farming communities, we're going to be looking out for those organophosphates. So do we have to retreat and actually get PPE on? Can we get the patient out safely? Monitoring. So we're going to be looking at the standard ones whilst they're seizing, is trying to get an SpO2 and potentially an end titles as well. Cardiac monitoring and blood pressure would be nice. If you've tried to put cardiac monitoring on a seizure patient before, generally they'll get tangled. but they are nice. And the blood pressure may be unreliable because they've got such an increase in their tone. And of course, we're going to be going for the BGL and the temperature. Now, I guess, more in-depth investigation we can utilize is the ISTAT. So that's a good indicator to sort of tell how long they've been seizing for, because they'll have higher lactate levels, as we said before. They can also provide a good indicator on if they are electrolyte depleted, and that's going to help us down the track, so post-seizure management, and it'll even help the hospitals with ongoing management as well. So the pharmacology, midazolam, big one. So it's a benzodiazepine, as we know. It's utilized not only for seizure termination, but as well as managing agitation and airway maintenance. So we're going to be using that FNM infusion. But how midazolam works, essentially, midazolam makes GABA more attractive for the GABA receptors. So it increases the affinity for GABA at those receptor sites, resulting in that influx of that negatively charged ion that we spoke about earlier, that chloride, producing an inhibitory effect, resulting in termination of that action potential, we hope. Second line, the hard one to say, levetiracetam, also known as Keppra, which we will say from now on. So Keppra is an anticonvulsant. Now it interacts with a synaptic vesicle protein 2-alpha. What that protein is it actually regulates some presynaptic neurotransmitter release, regulating that action potential. So how Keppra works, it binds with that protein, and it also I guess increases the inhibition of the presynaptic neurotransmitter release. So it's almost as if it's cutting off that glutamate in essence. And it also controls the amount of calcium by depressing that calcium grade current. Last but not least, magnesium. So it is the preferred medication when it comes to eclamptic seizures. At the therapeutic level, so the dosage that we provide, it actually blocks that NDMA receptor site in that excitatory pathway. So by blocking that site, it decreases the amount of the positively charged ions that are allowed to enter through. And it also competes with calcium in that presynaptic area, so decreasing the amount of, as it says there, the calcium dependent action potential, because magnesium, funnily enough, is an actual calcium channel blocker. So the nuts and bolts of it. So basic management, we're going to be doing our doctor's RACVD, as we do with every patient that we come across. So first, we're going to be looking at the position of the patient and if there are any surrounding immediate dangers. So we're going to be looking at furniture. Is there anything close to the patient that they can potentially grab during their seizure and harm themselves? So it'll all be, they won't have any control. So we want to clear the area around the patient. We want to request backup if available, because many hands make light work, and there is a bit to do with these patients. Next, we're going to be looking at airway. So do they require suctioning? Do they have trismus? Can we get any airway adjuncts in? And as we know that their oxygen demand is quite substantial, so we're going to be applying high flow oxygen. Then we're going to be going with the benzo, so midazolam. The dosages are all going to be service dependent, but for this, we're going to be utilizing ambulance Victorias. So IM midazolam, 10 milligrams in a large muscle mass, so preferably the lateral thigh, and we can repeat that at 10 minutes. If we can get IV access, and we can administer IV midazolam, so anywhere between 2 milligrams to 5 milligrams. For pediatrics, it's service dependent. Generally, the services will go on either an age or a weight basis. Weight basis is generally around 200 micrograms per kilo, with the maximum amount being 5 milligrams. So further management. So this is the management for more of that status patient. So a patient that's been essentially seizing for a period of at least 20 minutes and has been resistant to midazolam. So we're going to be looking at Keppra, so 60 milligrams per kilo, max dose being 4,500 milligrams. We're going to be diluting that into a 100 milligram normal saline IV bag, and then running that over 5 to 10 minutes. Magnesium, so generally 20 millimoles over 20 minutes. That's an infusion, so it's either by a spring fuse or whatever type of infusion device that your service has, but it'll be 2 vials diluted with 10 mils of normal saline. If we are unable to get control of the airway, or the patient is unable to control their airway, then we're going to be looking more down the RSI route. So we're going to be inducting with ketamine 1.5 milligrams per kilo, and paralyzing with rocuronium being 1 milligram per kilo with a max of 100 milligrams. With RSI, we do have to think about our ongoing sedation. So as we spoke about before, that fentanyl midaz infusion, we may need to look at getting some vasopressor therapy if they have a reaction to the actual sedation or the paralytic. And then we're going to be looking at the ventilation side of things. So do we have enough oxygen on scene if it's going to be a prolonged extrication? Do we need to request backup for more oxygen? And does as we'll talk about in the transport section, does the oncoming hospital have the capability to actually manage an intubated patient? And then we're going to manage all of the other conditions as they become prevalent. So our hypoglycemia, we can manage with IV 10% dextrose. The TCA overdose, we can look at our sodium BIC for that, and just manage the conditions as they arise. Transport considerations. So the rural areas are the main ones that actually have to think about this. So they can be hundreds of kilometers or hours away from a closest large hospital. So they're going to have to bypass a local clinic, especially if they have had to intubate the patient. So they're going to have to look at future planning. Do they have enough medications to assist with airway maintenance as well as seizure termination? Are they going to have to request air assets? So is the weather going to be all right? Will a helicopter reach them? Do they have a landing zone planned? Is there going to be fixed wing? How close is the nearest airfield? All of those sort of things. And then the closest backup crew. So the closest backup crew could be, again, 100 kilometers away. So what local resources do we have? Do we have fireys? Do we have police? Or do we have like the volunteer first aiders? Anybody that can help with extrication and potentially driving. Metro areas don't really have to think too much. So all we have to think about is how long is it going to take my backup to get here versus how long does it take me to get to a hospital. We've got the luxury of multiple hospitals, and we've got that luxury of multiple crews that can assist, because ideally we want two people in the back. So one to push medications and look at the monitor, and the other one to just focus on airway itself. Leadership and teamwork. So as the team leader, you need to remain calm, confident, and collected. That way, your team will see that and they will sort of embrace that embodiment as well. Because as we know, anxiety is contagious. We need to ensure that we've got a good situational awareness of the scene and know what each member of our team is actually doing. Seizures, for some reason, tend to have a high propensity for medication errors. So by utilizing a closed loop communication, we can avoid those errors and provide pregnant pauses so that our team members can actually take the time and ask questions or just clarify doses. You need to know the strengths of the individuals within your team and delegate the tasks accordingly. So one person might be a jet at airway, while the other might be excellent at extrication or drug management. So you're going to, task accordingly. You're going to utilize a collaborative approach. So involve all members of the team into the decision-making process. And that means that everybody feels that they have a say, and just sort of reiterate that the patient's safety comes first. You're going to provide ongoing encouragement to the team. And I know it's hard these days with the workload, but if you can, then have a debrief post the event, especially if there's been errors or just things that you've noticed could be done better, because that's the only way that we learn is through those debriefs and identifying the weak points in our practice. And these are just some references for your perusal. Thank you very much. I hope you've enjoyed today's presentation. As always, I've enjoyed presenting it, and I'll see you again soon. Thank you very much.